What are the slides, though?
Thank you very much for the invitation, and thank you also for this change. It was important because we have a little bit of delay in the schedule, so I will go straight forward with the presentation. So, yes, so tips and tricks for the tricuspid. Of course, the most important part is the interventional part when we hear tricuspid regurgitation and edge-to-edge therapy, but I would like to present a few slides which in my opinion are very important also to understand a little bit better the tricuspid, because all of us in the meantime, we know how we have to implant a device in an edge-to-edge therapy after such cases with the mitral valve. But we have to understand that the strategy in the tricuspid valve is a little bit different. So first of all, as you already mentioned, the tricuspid valve is a forgotten valve. It's actually in black box. And as we can see here, the incidence of the aortic stenosis is about 2.8% in older patients, and in mitral regurgitation, 9.3%. But the tricuspid regurgitation is something in between. It's almost 4%. That's why I understand and can underline that the tricuspid valve, and especially the tricuspid regurgitation, is a forgotten valve. A few things about the graduation of the tricuspid valve, especially the regurgitation. We don't have only 3 grades. We have actually 5 different classifications. We have the mild, the moderate, the severe, but in the case of tricuspid regurgitation, we have also the massive and then torrential. And this is important to understand because the results are depending on this graduation. If we have a torrential regurgitation, something like free flow, so to say, to achieve a severe regurgitation after a therapy is a huge step. We cannot make a torrential, cannot change the torrential regurgitation into a mild regurgitation after an edge-to-edge therapy. But we will see in the next slides also what's the outcome, the clinical outcome in such cases. The classification, the most easy classification depends on a few parameters like PISA, like ERA, and vena contracta. The PISA is a relatively simple parameter to classify, to make the measurement in the echocardiography. We can make the calculation also automatically, but it's terribly inaccurate. So let's see an example here. For example, in that case, we have a PISA of 7 millimeters. The area, the calculated orifice is 0.4 centimeter. But what about that case? Actually, it's a case with, so to say, a free flow. It's a really torrential regurgitation, but we don't have actually any PISA. And this is the problem with the PISA. The PISA begins very low, goes up, becomes up to 7, 8, 9 millimeters, and after that, we have a huge gap in the valve. The PISA goes again down, so it becomes lower. And this is something we have to take into account if we base our measurements, our evaluation of the tricuspid valve, especially with the PISA. Much better is the vena contracta, but the biplane vena contracta, not only in one plane. As we can see here, we have regurgitation of the tricuspid valve, and we see the valve in 2 different axes, biplane actually. And as we can see, we have 2 different vena contractas. The one on the left side is 25 millimeters, the other is 9 millimeters. So a mean is about 17 millimeters. And that means that we have torrential, massive to torrential regurgitation. I go on with the complex morphologies for the edge-to-edge therapy to understand which parameters are very important to take into account before we begin with the procedure in order to optimize our strategy. As I say, the strategy is much important in the edge-to-edge therapy for the tricuspid. A lot of people means that the presence of pacemaker lead can make the situation much complex, can impact the results. Unfortunately, or thanks God, not. That's not the main problem. The main problem are the gap size, the gap between the leaflets, the tethering distance. I will explain that in the next slide what we exactly mean with that, and the tricuspid annular diameter. The bigger the atrium and the bigger the ventricular is, the bigger is also the problem with the annulus diameter. And this is a study from Lourdes, but we have the same results also from Taramasso and from other colleagues that present also the same effect of the coaptation depth and of the annular diameter, also of the tending area. So that means this is some parameters we have to calculate, to take into account before we start the procedure. What's exactly the tending or the coaptation depth? As we can see here, we have a valve with a gap and the tending of both leaflets, as we can see here, the septal, and in that case, we have the posterior one. So what we have to do is to calculate the distance between the ring and the coaptation point. This is the tending, or this is actually the coaptation depth. And we can also calculate the orifice of this triangle between the ring and the two leaflets. So if we have an orifice that's bigger than 1.6 per centimeter, or a high coaptation depth that is bigger than 0.76, and we have actually not the best parameters to begin the procedure, we will achieve a good result, but we will not have the best result. And we have a high recurrence rate in such cases. So that means we are too late in that case. But on the one side, we have the interventional result, and on the other side, we have the clinical result. And this study shows very clear that maybe we will not have the best interventional result in such difficult cases with complex anatomy, but we will achieve at least a very good clinical result. So as you can see here, we have again the same patient with a 9 millimeter gap and a 28 millimeter gap from the other side, as we have already seen the other echo in prior slides. And on the middle, we have two panels. The upper panel shows the interventional result, the TEER reduction after edge-to-edge therapy. And as we can see, if the gap is only 7 millimeter or till 7 millimeter, we achieve very good results. Almost 80% with mild to moderate regurgitation after the therapy. But if the gap is between 7 and 10 millimeters, only 40% of the patient has residual mild to moderate regurgitation. And then we have a huge gap, more than 10 millimeters, and only 1/3 of the patient achieve a mild to moderate regurgitation after the therapy. That means almost 70% of our patients with a huge gap, with a massive or torrential regurgitation, remain with the severe or severe plus regurgitation. This is the interventional result. But what means that for the patient? Because the patient doesn't matter about the interventional result, he matters about his dyspnea. So the same classification, the same patient, the same groups were analyzed. We have the analysis of the groups also according to the clinical result, according to the dyspnea. And we show that in the lower panel. Groups, the clinical result was the same. That means almost 50% of the patients had a good reduction of the dyspnea, almost NYHA 1 or NYHA 2 classification. In all three cases, also, if we had severe regurgitation, but the severe regurgitation was before the procedure torrential. This reduction of 2 grades helps the people to have a much better clinical situation after the procedure. And this is, I think, the most important thing, not only the clinical result, not only the clinical outcome, but not only the interventional outcome, but much important is the clinical outcome. I will go on further with the complex morphologies for our strategy. So it's very important the pre-screening, not only to see the gap, not only to see the coaptation depth, but also the morphology of the valve. We say always tricuspid valve, but we know now that we have not only 3 cusps in this tricuspid valve. Sometimes we have 4 cusps and sometimes we have 5 cusps, especially if we have an indentation in the anterior and posterior leaflet. And the study shows again that the higher the leaflets, the worse the interventional result. So again, a study from Sigura, and we show here that patients with 3 leaflets, they have much better interventional result with almost mild to moderate residual regurgitation in 80% of the cases after the procedure. In cases with 4 leaflets, the mild to moderate residual regurgitation is about 60%, and the other 40% is severe or severe plus regurgitation if we have 4 leaflets. With 5 leaflets, the situation becomes worse. So that means the more leaflets, the worse is the interventional result. Some interventionalists means in that case we have to go with a transcatheter annuloplasty further, but we have other studies that shows that for the transcatheter annuloplasty, the the number of cusps of leaflets doesn't play an important role. Here are the results of analysis of Korber, and we can see that if we have a more complex situation comparing to a normal situation, the reduction of 1 grade of regurgitation is the same in both groups, complex and normal, and the reduction of at least 2 grades in the regurgitation is again the same in both groups, normal and complex. So that means that annuloplasty doesn't play such an important role if we have much more leaflets, because annuloplasty doesn't work with the leaflets, it works only with the ring. Now, when we have to implant our clips during the procedure, we have actually 3 options: septal anterior, septal posterior, and anterior posterior. And this is very rare, and I would recommend to avoid that if it's possible. Why that? The experience shows that if we put a clip over there, we have a completely different situation comparison to the mitral valve. We have a much more difficult and strange 3D anatomy of the tricuspid valve. So if we put a clip there, maybe we optimize a gap in the anterior-posterior commissure, but we change completely the morphology of the anterior leaflet, especially of the anterior leaflet, because it's more mobile. That means we have more tension in the anterior leaflet. We pull the anterior leaflet, and that leads to a new gap between septal and anterior cusp. So we close maybe a small gap between posterior and anterior leaflet, but we open a new one between septal and anterior. This is an option we have to choose only if we have made a big cuspidization. That means if we close completely the gap and the cusp between, and if we close completely the gap between septal and anterior cusp, and then we put a third clip, a third device between anterior and posterior leaflet. So we have the bicuspidization, and we close also a gap between anterior and posterior leaflet without to have any problem to open a new one gap. As I say, avoid to put only one device in the anterior-posterior commissure. We already spoken about the bicuspidization. That means to put 2 or 3 devices in one of the commissures in order to close completely this commissure. Or the other strategy is the Clover strategy, something we learned from the cardiosurgeons. They stitch, make 2 stitches between anterior and septal leaflet, or posterior and septal leaflet, and they close only the middle of the valve. So we have 3 openings, so to say, in the valve, and we try to minimize the reduction. The most used, of course, position is the anterior septal position. After that comes the posterior septal position, and as I say, at the end, the posterior anterior. Only in very rare cases and only in combination with other clips in the other commissures. Of course, the choice of the device plays an important role, and I don't want to speak between the 2 different categories of devices, the Pascal and the clip, but to analyze a little bit and to understand the importance of the different parameters of these devices. So we have the small devices with 9mm arms, both companies, and we have the large devices with 12mm or 10mm arms. Makes that a difference? Yes, of course, that makes a difference. The tension on the leaflets is bigger. And this is really important before we choose the device. Not only the length is important, the length of, especially of the posterior leaflet, of the septal leaflet, but also the quality of the tissue is very important. That means if we have a very teeny very small leaflet, septal leaflet, please don't use the big devices. Also, if you have enough length. Why that? Because you have a lot of tension, and we saw cases that perfect, but after the implantation, after the releasing, we have the septal leaflet broke because of the tension. We have a scar over there, and this is a new gap that we create due to the tension. The bigger the devices, the bigger also the tension is. So if you have not good quality of tissue, choose a smaller device. Also, if you have enough length, because the tension is lower and the risk to damage the leaflet is also lower. Of course, the bigger the device is, it's much easier to solve the problem. That's why the tension at the moment is to use the bigger devices, especially here in the analysis of the clips. So the most groups and the most interventionalists, they use the XT and the XTW devices with good results, as we see from the analysis. And I want just to mention that before we start, we have, especially with the therapy of the tricuspid, we have to know that we will use most common two devices, two different clips or two different Pascals. That shows also the Triluminate study. So they have an average use of 2.2 clips, and the Bright analysis, they saw also that in an average of 1.9, that was almost 2 clips in every case they needed to use to achieve good results. So to sum up, before you start, and I don't want, as I said, to analyze again the implantation technique, because it's the same with the mitral valve, but the strategy is different in comparison to the mitral valve. We need to take care about the tethering of the leaflets. If we have large gaps, we have to avoid maybe this therapy and go to orthotopic or heterotopic valve implantation. And if we have a large annulus diameter, we have to take into account the tension we use on the leaflets, with result that we can lead to a break of that leaflets after the implantation. So if we have such parameters in the pre-screening, maybe we have to consider that we are too late with the edge-to-edge therapy, and to change that in another therapy, especially in the new area with the valve implantation. Thank you very much for your attention.
Thank you very much. That was an excellent overview with tips and tricks. I think we're running behind, so we're going to move on to the next talk. Dr. Spargias is going to